about to do a case which is going to demonstrate some of the principles of interpedicular minimal access surgery. Fundamentally, it's a typical lumbar degenerative case with instability issues, with reconstruction issues, and stabilization issues. One of the differences in the way we approach radicular symptomatology in the lumbosacral spine and reconstruction options is we have more tissue-sparing, atraumatic, small incisions that allow for more efficient segmental decompression and stabilization in the lumbosacral spine. One of the goals that I've had personally was to make lumbosacral spine surgery more analogous to anterior cervical disc surgery, which gives a much more predictable flow, sequence, and efficiency to case management and goal strategies. We would like to create a platform where we can give surgeons of all different strategy types, whether it be open, mini-open, or microsurgical, the opportunity to improve their own efficiency, their own operative times, their own accuracy of pedicle screw placement, to use some tricks that we've developed as far as pedicle screw placement to better understand the three-dimensional anatomy of the lumbosacral spine, to use those screws once well placed as a neuronavigational tool to accurately find the central canal, the foramen, the disc space above the extraforaminal space. A marker deep in the hole really gives you a very valid and very, very quick and accurate indicator of where you need to go next, depending on what your plan is. There are three major phases of these procedures. One, the preoperative planning, which includes all the way up to the marking of the skin done fluoroscopically on the operating room table. Two is placement of the screws and the decompression. Three is a stabilization reconstruction phase. On lumbar cases, we'll use biplanar fluoro. We'll do all our preoperative marking first, which will be done starting with lateral plane, going to AP plane. We'll mark the skin incision, figure out our target. At that point, we'll come out, we'll expose, and begin with the screw as a first step. There's no question there's a dual role in putting the screws in first. One, there's a lot less bleeding and oozing at this phase of the case, which really reduces the blood loss considerably in terms of putting the screws in first. The second reason it's an advantage at this point is really once you've done all your dorsal midline decompression, particularly in a percutaneous wound, the nerve sac, the thecal sac, the nerve roots are all potentially exposed to the introduction and delivery of instruments in and out of the wound. Part three is really the neuronavigational component of the screw itself. In using a headless screw, once you've placed them fluoroscopically, with absolute certainty you know the regional anatomy around each pedicle screw. Once we have the screws in, I think we have the best neuronavigational tool currently in existence. It's in situ. We know exactly where, with a 360-degree radius, every element, the central canal medially, the foramen or the nerve root inferiorly, the disc space superiorly, the extraforaminal space laterally. Like the dial on a clock, you can do your preoperative planning using that radius around each headless pedicle screw. The nice thing about doing it on a segmental interpedicular approach is once you finish one level, you're done, you move on. Second level, you move on. And the flow for the case is much more analogous to an anterior cervical decompression reconstruction, where most surgeons are very comfortable with this very methodologically pure and elegant pathway that we have of finishing a task and moving on, which overall has led to a very, very much lesser morbidity type environment for lumbosacral spine decompression and reconstruction options. The bottom line is whether you're doing it open, big open, mini open, or what we're soon going to be doing, which will be a true multiple port endoscopic. At the end of the day, you can accomplish it safely without compromising the objectives, without compromising the stabilization, without compromising the reconstruction, and with the use of biologics, lessen dead space, improve surface area. We're seeing fusion rates that are approaching high 90s percentile. But even if you're doing an open, large approach, more specificity, faster screw placement, less blood loss, is going to improve your patient's outcomes considerably, and consequently worth taking the time to focus on the steps. How far into the 3 tiers of advancement from open to mini open to micro any surgeon chooses to go is entirely a personal choice. But no matter what, the goal is to do it in a less traumatic, less time consuming, more efficient, more productive way that's safe for his patients.